in the course in this session, please go take a look at that lecture. I explained in detail every type and their complication, their management, everything about them. So you said, of course, periorbital swelling is also could be something, right? Periorbital swelling could also indicate, it may be indicating basilar fracture, right?
Yeah.
Can be. Yeah. So, but it doesn't always indicate basilar fracture. It can be just a periorbital hematoma from the trauma itself, or another reason of periorbital swelling that happens to be in this patient. So it still is an indication. But if they told you a confirmed diagnosis of Lifford tree, this is confirmed that there's Lifford craniofacial dissociation. So that is confirmed 100%. It means definitely that's an indication, right? It's a stronger indication. You can say it's a stronger indication than if you just say periorbital swelling. That's just from the textbook. This is explaining from the textbook. Okay, let's see the next question.
So a 40-year-old woman is admitted to the emergency department following a road traffic accident. She sustains a complete transection of the spinal cord at C7. Which of the following reflexes is the earliest to recover following the spinal shock stage? So plantar reflex, ankle deep tendon, biceps deep tendon, delayed plantar bulbar reflex. I'm not sure.
Yeah, so DPR or delayed plantar reflex, right, is the earliest reflex that returns. It's an abnormal form of reflex, of plantar reflex, that when you do the plantar reflex, when you stroke the sole of the foot, there's delayed toe flexion. There's delay in the flexion, right? And there is sustained flexion. Even when you remove the stimulus, the return to the neutral position is slow. That is the earliest reflex that return. Some, Dr. Hala, Dr. said, what about E, bulbocavernosus reflex? I agree. Bulbocavernosus reflex is the most clinically relevant or important reflex that returns in spinal shock stage. When the bulbocavernosus reflex returns, it is meaning that this patient is no longer in spinal shock stage. It means that you can formally now test for sacral sparing, right? We talked about that, sacral sparing, which can influence the prognosis and the prospect of motor recovery following spinal cord injury. But it is not the very first reflex to return. It is the most clinically important reflex to return, but it's not the first. You can check that in the reference in this question is the PubMed. You can see it in PubMed. Of course, it's a recognized authority all over the world. So, according to them, they say that delayed plantar reflex is the first one to return, earliest one to return, followed by the bulbocavernosus reflex closely. But for clinical purposes, the bulbocavernosus reflex is more important, right? But it's not the first to return. That's the thing. Yes, please. Can anyone carry on reading? Dr. was feeling like sore throat. If anyone can please continue reading, I would appreciate that. Okay, so Dr. Hala, she wants to read, or she's, are you saying okay for the question? Just, you can just raise the hand. Why shying out? Just, I think it's good to participate in everything. Well, not in every single thing, but it's good to participate in general. So, when I first started, I remember something in participation. When I first started practicing as years ago, you know, when you first time in the OT, you're not helpful. Is that right? You are actually dangerous. So I had no idea about, you know, how to operate or do anything like that. I had no idea about these things at all. So the consultant, when there's small bleed, I take the gauze, put it in, and I don't release it. It's like, please release that. Just don't. I can't see anything. You're just putting towels all over the place. Anyway, yeah. Anyone would like to read, please, so that we can continue to the next question. Okay, no problem. I will read. So let's see. Next one. Okay, that's basically a calculation, right? 6 kg child is before I read this question, I have a question for you guys. I didn't clarify it. What is sacral sparing? I think we talked briefly about it in previous session. What is sacral sparing? And what is the importance of sacral sparing?
Sacral sparing, indicating complete spinal cord injury.
Yeah, that's good. So if there is no sacral sparing, it means complete spinal cord injury, right? So no, if there is no sacral sparing, it means complete spinal cord injury, which is definitely not. If there is sacral sparing, it means incomplete injury, whatever the pattern of incomplete injury may be, but it is an incomplete type of injury. So it means there's motor recovery. The aspects of sacral sparing include perianal skin sensation, big toe flexion, and rectal motor responses. Three things. Perianal sensation is intact, big toe flexion and rectal motor function is intact. Any combination of these is called sacral sparing. So if I tell you that if someone is now presented, for example, a month back after a road traffic accident with spinal cord injury confirmed on MRI, and now the bulbocavernosus reflex has returned, and now we would like, of course, sacral sparing, definitely you cannot test it until spinal shock stage has elapsed, meaning there is bulbocavernosus reflex. In that case, you can start testing. Now, when you are starting to test, you test if I tell you regarding the chances of motor recovery, what perianal sensation correlate best with that? That was one of the recent exams, this question. So what do you think? Excellent, Dr. Rimaz, you are always amazing. You said pain. Very nice. Why pain?
The fiber that carry the pain sensation is relatively close to corticospinal tract, which carry the motor fiber. That means it will be intact also and good prognosis.
Amazing, really. Yeah, that's correct. So what Dr. Rimaz said, that this is the spinal cord, these are the dorsal horns, ventral horns, right? And okay, this tract is the lateral spinothalamic tract, which is carrying pain and temperature sensation here and here, laterally, right? Laterally, here and here. It is carrying pain and temperature sensation. Next to these tracts, which is here and here, very near to them, is the corticospinal tract, which carries motor innervation, corticospinal tract. So it means that if there is no pain sensation, there is a very high chances that the corticospinal tract is also damaged in that injury because of anatomic proximity. So anyway, those are some of the things that I wanted to say. Let's see the next question. It's a 6 kg child. He's admitted to pediatric ward. He's dehydrated. He's nil per oral, meaning that you have to give him maintenance. Maintenance 6 kg child. So maintenance fluid is according to holiday cigar formula. If this kid is 6 kg, so how much fluid would you give them in a 24-hour? Yeah, so it's a simple calculation. For every first kg, you will give 100 ml for every first kg. So suppose if someone weighs 10 kg, you will give them a liter. So that's in a 24-hour, of course. And for every kg after the first 10 kg, you will give half of that amount, that is 50, right? So suppose someone weighs 20 kg, you will give them 1.5 liters. For every kg above that, you will give them 20 ml per kg for every kg above that. Okay, let's see that one that says patient complains of reduced taste on the anterior two-thirds of their tongue, mild discomfort, outer ear too. Which of the following is a general sensory afferent supplied by facial nerve? GSA, general sensory afferent. B, right? B. That is external auditory meatus, yes. So the taste sensation to the anterior two-thirds of the tongue is special afferent. It's a special senses, the vision, the smell sensation, and the taste sensation are special senses, right? So they are abbreviated as SA, special afferent. The ganglion which receives special afferent, what's that called? Ganglion of facial nerve, which receives special afferent nerve fibers from the oral part of the tongue. That's called what? Yeah?
Geniculate ganglion.
Geniculate ganglion. Yeah. So it is the geniculate ganglion which is found within the facial canal. Geniculate ganglion. Right? Okay. Don't confuse geniculate with Gasserian. Gasserian ganglion is in the Meckel's cave, which is the sensory ganglion of the trigeminal nerve. Okay. So if I tell you, what is the branchial efferent of facial nerve? Branchial efferent. BE, branchial efferent. What does that mean? Branchial efferent. Anyone knows what's the meaning of branchial efferent? It means, yeah, it means motor innervation to muscles derived from branchial arches, right? The facial nerve is associated with second branchial arch, so it supplies the second branchial arch, give rise to muscles of facial expression, some other muscles as well, but mainly muscles of facial expression. So the branchial efferent of the facial nerve is those muscles derived from the second arch, which include all of the facial muscles, which include the posterior bilio-digastric muscle, which includes stylohyoid, and what else? Stapedius, right? Auricular muscles, and occipitalis, part of occipitofrontalis, right? All of those are derived from branchial arch number 2. So So it's like any nerve, cranial nerve associated with a branchial arch. The muscles derived from this arch will be supplied by that nerve, and that nerve is said to have branchial efferent fibers. Okay, they are different from general somatic efferent, GSE. GSE stands for general somatic efferent, right? Which are those skeletal muscles not derived from branchial arches, right? This is called GS, general somatic efferent. All right. Anyway, okay. This next question is saying they are talking about old women, 79 years old women. She has cervical lymphadenopathy, right? And biopsy was done to confirm malignant node enlargement. There is no axillary or inguinal lymphadenopathy. So it's in the neck. On investigation, there is mediastinal enlargement as well identified. What is the diagnosis for that case? What do you think? Non-Hodgkin, because of the age, right? Mainly because of her age. As you can see here in the explanation, non-Hodgkin lymphoma is commoner in older age groups. Okay, I have a question. Lymphomas are derived from which cells? Yeah, simple question. Lymphomas are derived from which type of cells? Cell of origin. Usually B lymphocytes. There are some lymphomas which are T cell lymphomas, but most lymphomas are derived from B lymphocytes, right? Okay, what kind of T cell lymphomas that you know of? Lymphomas derived from T cells. Just give me two examples, will be enough. Two examples of T cell lymphoma. Yes. Number one, is lymphoma associated with Hashimoto's? Guess the tumor is B cell lymphoma. Guess the tumor is B cell. One example is Hashimoto's thyroiditis. Lymphomas associated with Hashimoto's thyroiditis are T cell lymphomas. And mycosis fungoides. Mycosis fungoides is a type of cutaneous T cell lymphoma. Don't be fooled by the name. Name implies fungal situation, but it's actually a lymphoma called mycosis fungoides. Okay, that's one question out of our way. Most lymphomas are B cell, except for few exceptions like Hashimoto's and mycosis fungoides. The next question, do you think that if you take a cell from non-Hodgkin lymphoma growth, malignant cell, and you stain it, immunohistochemical staining, do you think you will see B cell markers or no? Do you see, like, for example, CD10, CD20, these are B cell markers, right? So if you take from non-Hodgkin lymphoma growth and you stain it, would you think that you will see B cell marker on the surface or no? You will see, yes, nice, yeah. You will see B cell marker because non-Hodgkin lymphomas are B cell lymphomas. Okay, suppose another patient comes along and they have Hodgkin's lymphoma. Similarly, you take a biopsy and you stain it. These malignant Reed-Sternberg cells seen in Hodgkin's lymphoma, when you stain them immunohistochemically, would you say that it may have B cell marker on top of these cells? Yes or no? would you say that they will have B cell marker? Dr. Isra Ayub said yes. The answer is no. No. Yeah. The thing is that, except there are few exceptions, lacunar cells, but majority of cases, they, popcorn cells, the majority of cases, they are negative for B cell markers, negative. And despite they are actually B cells, they are actually B cells, they are derived from B cells, but those particular type of malignant B cells do not express B cell markers. That's an important immunohistochemical difference between Hodgkin and non-Hodgkin lymphoma. It's one of the basic differences that most of Hodgkin lymphoma situation is not positive for B cell. They are B cells, but not positive. They don't express on the surface B cell marker. Whereas in Hodgkin, they express. Okay, let's see the next question. 40-year-old man, he's undergoing renal transplant, is that right? Chronic kidney disease. He complains of abdomen, investigations reveals calcium, renal stones, and serum studies show high PTH and high calcium and normal phosphate. What is the problem? He had a history of chronic kidney disease. And now, after a transplant, he's presenting with high PTH, high calcium. Tertiary, right? Tertiary hyperparathyroidism. So, if you take biopsy from the parathyroid glands in a patient with tertiary hyperparathyroidism, what kind of abnormality you will see? What's the main problem? Hyperplasia. Very excellent. The next question is, what types of parathyroid hyperplasia you know of? What kind of parathyroid hyperplasia you know of? So there are two types, sheath cell hyperplasia and water clear cell hyperplasia. Water clear cell hyperplasia and sheath cell hyperplasia. I didn't understand the previous question. They're saying what says undergo, so what? It doesn't make any difference, right? Calcium level increase even after renal transplant. Look, let me tell you what's the underlying pathology. In patients with chronic kidney disease, they have hypocalcemia and hyperphosphatemia. Hypocalcemia because the kidney is not activating vitamin D. That's problem number one. Problem number two, there's hyperphosphatemia because there's inability to excrete that. Kidney is not working. Both of these stimuli stimulate the parathyroid glands. Initially, the problem is secondary. Initially, the glands, so these are 4 glands, 1, 2, 3, and 4. Let me just draw them here. Okay, 4 glands. Initially, the problem is that there is diffuse hyperplasia, usually sheath cell hyperplasia, meaning that all of the glands are symmetrically enlarged, diffuse hyperplasia. There isn't any nodularity in the gland, okay? Now, these are reversible changes. When you remove the stimulus, which is hypocalcemia and hyperphosphatemia, these changes will regress. Is that right? But if there's persistent stimulus, that this patient with chronic disease, their hyperphosphatemia is not treated, their hypocalcemia is not treated, and they've been having this situation for a very long time, nodular hyperplasia starts forming. That the gland will assume nodular pattern. This nodularity is irreversible. Okay, so it's not diffuse anymore. It's called nodular hyperplasia. Okay, this nodularity is It is not reversible, meaning that once the glands develop nodularity, we will say this is tertiary hyperplasia. This is pathological definition, not clinical. The pathological definition is that when nodularity develops in the gland, we will say this patient have developed irreversible change in the gland, meaning it's autonomous. Even if the stimulus has been removed, it will continue releasing PTH. Okay? Now, if this patient receives a kidney transplant, if they receive a kidney transplant, these changes will not be reversible. But clinically, we will define that this patient has tertiary hyperparathyroidism and thus surgical intervention is needed after 1 year of their transplant. After 1 year of receiving the transplant, the biochemical abnormality is not reversed, meaning this patient is clinically defined as having tertiary. But if this patient receives the or does not receive the transplant, it does not matter for that. Once the change has been there, it will always be there. You get the idea? That's the main important pathological difference. So you said he's undergoing or undergone renal transplant. It doesn't matter, right? It's not important. Now, it's important, after the transplant, clinically wise, if there's no indication of nephrectomy, like, for example, nephrocalcinosis or something else, you need to allow 1 year, right? If there's no reversibility after 1 year, then it becomes important. Let's see. I hope that's clarified. You can stop me at any moment if you need something. Dr. Hala, I meant pathological type. I'm not talking about etiology of parathyroid hyperplasia. I'm talking about microscopic types. Pathological types, there are two main types: sheath cell hyperplasia and water clear cell hyperplasia. Let me write them down. Sheath cell hyperplasia and water clear, it's called like this, water clear cell hyperplasia. Okay, that's pathological types. In sheath cell, there are sheath cells. In water clear cell hyperplasia, the cells are large, they have vacuolated clear cytoplasm, and they look nothing like sheath cells, but they think they are derived from sheath cells. And these cells produce PTH also. So both types, pathologically, they can cause hyperparathyroidism. Okay? In men, by the way, Dr. Hala said in men, in multiple endocrine neoplasia. If I ask you in men type 1 and in men type 2, yes. If you take biopsy, parathyroid gland, in men type 1, what's the finding? Adenoma, yes. Okay, in men type 2, usually adenoma. Hyperplasia can be there, but usually adenoma. And in men type 2, that's 2. Do you see? This is 1, this is 1. You put a bar in between, becomes H, hyperplasia. Okay? So min 2, you can remember it. There are 2. You just put a cross bar, it becomes H, hyperplasia. Hyperplasia is more likely with min type 2. Okay? In cases of min type 1, the hyperparathyroidism is more severe compared to cases of min type 2. Okay? So it means that surgical treatment is more likely with min type 1 compared to min type 2. But anyway, that's just a detail. If you want to know about it, it's okay. So, yes, I'm gonna save you the trouble. This is a case of that. That's a case of, right? Elbow, radial head subluxation or dislocation. That. Simply put, there is radial head subluxation. Also, yes, commonly called housemaid elbow. I think maids have been aggressive back in the day. They were pulling children. I'm not sure why they've called it housemaid elbow. I'm not sure about that. How to manage this condition? This condition is the type of condition that will make you look like a superhero, right? Because you can immediately improve the situation, right? Instantaneously improve the situation. You come in, you do a few things, right? And the kid is just fine immediately afterward. And the parents, they will say, oh my God, this is the best doctor in the world. It's that kind of condition, right? So it's a simple reduction and then discharge, right? Reduce the elbow without analgesia. Without analgesia, you just reduce it and bye-bye, right? The kid can go home. Simple as that. Elbow. Yeah, it's called nursemaid, not housemaid. Nursemaid elbow or radial head subluxation. Okay, very common injury. There are two ways to reduce it, right? Flexion, extension, and what else? It doesn't require pain medication. It doesn't need any pain medication. The child will feel pain, right? When they come to the emergency department, they are holding their head in a particular position and they won't let anyone touch it because they know it's painful when you touch it. But as soon as you reduce it, the pain goes away. And the reduction can take few seconds only to do it. So you don't need to give general anesthesia or local anesthesia or anything, any type of anesthesia. It can be corrected very quickly. Okay, and they can be discharged afterwards. Anyway, so the nursemaid's elbow or radial nerve subluxation, it is emergency, not considered as child abuse, but if there's sign of trauma, yes. Well, that's a different thing, child abuse. So yeah, it can be a sign of child abuse. It's usually not a sign of child abuse. It's not one of those specific things. Child abuse, what kind of fracture pattern you would suspect, or what kind of orthopedic pattern? Number one, if there are posterior rib fracture, there's a spiral fracture, if there's scapular fracture, if there are fractures of different ages, on X-ray, it means this kid has been hit before in the past, they have received a sustained fracture in the past, and now another. And yes, head injury, especially in the non-walking age, right? Or extremity fractures in the non-walking age. He's not walking, so it's unlikely that he fell very hard to. Another thing is, which is the pathognomonic, they call it the pathognomonic fracture abuse or child abuse. It's called bucket handle fracture or metaphyseal bucket handle fracture. If you want to see that fracture, it's on the public channel in the Telegram. Just write bucket handle fracture. You will see all the detail about it. It is pathognomonic for child abuse, right? Because the mechanism of this fracture is to and fro, meaning the child has been shaken back and forth, and this child is under 2 usually walking age. So there is a metaphyseal corner fracture in the metaphysis around the tibia, around the knee. That is pathognomonic. If they ask you what is the most accurate, you can say sensitive for that problem, child abuse, you will answer bucket handle or metaphyseal corner fracture. So not necessarily, nursemaid elbow, not necessarily something very strong for child abuse. So a 50-year-old homeless man present with what problem? Multiple ecchymoses and multiple non-healing wounds. So deficiency of what? Very simple question. Deficiency of multiple wounds, multiple non-healing. So vitamin C, right? Vitamin C. Okay, the next question. A 40-year-old man sustains trauma. What is the body's physiological mechanism of keeping thrombosis under control? Body's physiological mechanism of keeping thrombosis under control. Protein C, right? Why not antithrombin 3, for example? Or why not plasmin? What's the reason? What's meant by keeping the body's physiological mechanism, physiologically, how the thrombus is kept to the site of injury? That's the meaning. The meaning is physiologically, you know, what's the purpose of that? Purpose that when someone gets injured, all of us know, right? When there's a vessel injury, suppose there's a vessel injury here, normally the blood at the site of injury should clot, should form a thrombus to occlude the site of injury, but it shouldn't spread to other sites. It should not spread to other sites. It should be kept at the site of injury, right? Here, at the site of injury. So how does the body does this? That's the meaning of this question. You have to understand what they want, because that's important. If you understand the question very clearly, you will answer. So they mean physiologically how, that's in other words, physiologically how the thrombus is kept to the site of injury, meaning under control, meaning at the site of injury, after a trauma event. The answer is, let me tell you, so that's healthy endothelium, right? That's site of injury, that's the rest of endothelium. Okay, now the nearby endothelium express something called, what's that? There's something here. Thrombomodulin, right? Thrombomodulin is expressed on nearby healthy endothelium. Now, when there's injury, of course, subendothelial collagen is exposed. Platelets come to stick here with the help of von Willebrand factor and glycoprotein 1b. And then a platelet aggregate will form and a thrombus. Of course, the coagulation cascade will also be activated, and the patient will develop a thrombus. Now, of course, what do you think? At the site of thrombus formation, is there higher concentration of thrombin or lower concentration of thrombin? What do you think? At the area where it's being formed, thrombin concentration is high or low? Yeah, it's going to be high, right? Because of thrombin generation. So it's going to be high. Now, this thrombin will spill over to the healthy endothelium. Now, this thrombin will form a complex with thrombomodulin. Suppose this ball is representative of thrombin. They will form a complex. This complex is called thrombin-thrombomodulin complex. Now, this complex, now thrombin is a procoagulant, but when it binds to thrombomodulin, it becomes anticoagulant. It becomes anticoagulant, the reverse of its function. Now, what does it do? It activates protein C. It activates protein C. So protein C, you can think about them as the gatekeepers. Those are the people that are standing here, right? And saying to the thrombus, you can't spread to healthy areas, right? So that's the mechanism of how the body keeps the thrombosis physiologically where it needs to be, at site of injury only, without spreading to other sites. Okay, so that's why answer is B, as you guys said, which is correct. Okay, this is the exact mechanism. Okay, let's see this question. That is basically a young, otherwise healthy woman, long-term steroid therapy for an autoimmune condition, present with non-healing wound. What's the reason for her non-healing wound? Obvious, right? Steroid delays wound healing. Okay, easy one, this one. Let's move to the next one. 60-year-old female. She's on steroid for what? For autoimmune hepatitis. She's scheduled for an elective femoral hernia repair. She develops Addisonian crisis after the surgery. She given intravenous hydrocortisone. Simply, hydrocortisone is superior to DEXA because why hydrocortisone is superior to dexamethasone?
It has a mineralocorticoid effect, unlike dexamethasone.
Yeah, excellent. It has mineralocorticoid, more potent mineralocorticoid effect, right? So it says here, hydrocortisone has more potent mineralocorticoid effect. Why we need mineralocorticoid action? For volume, right? Patient is hypovolemic. So we need salt and water to correct that. So hydrocortisone has mineralocorticoid action compared to DEXA. DEXA is more anti-inflammatory, but we don't need that now. We need the mineralocorticoid action to be more potent. Now, do you think under physiological conditions, with physiological doses, like endogenous glucocorticoids that are produced, do you think they have mineralocorticoid action normally and physiologically? Do they induce mineralocorticoid action in the body? Do you get my question? Let me clarify the question again. For example, someone who's perfectly normal, all of their biological parameters are perfectly normal. Normally, his cortisol or glucocorticoid, do they have or induce mineralocorticoid action in their body, in their kidney? The answer is no. Yeah, no. Under physiological situation, it does not have mineralocorticoid action. You know why? Why? Because under physiological doses, glucocorticoids in the kidney are broken down by something called 11-beta hydroxysteroid dehydrogenase enzyme. When there's excessive glucocorticoids, this enzyme becomes saturated. It gets saturated, right? And it doesn't have the capacity to break down all of that glucocorticoids. So those will start causing mineralocorticoid action, right? So under physiological conditions, glucocorticoids do not have mineralocorticoid action in the body. They can, but they can't, right? Why they can't? Because there's this enzyme, 11-beta hydroxy, whatever, dehydrogenase. This enzyme breaks down glucocorticoids before they induce their action. But if you increase it much, they will overcome the enzyme and start having mineralocorticoid activity, right? Anyway, that's just some physiology topic. Okay, let's see this question. A 65-year-old patient presents to the ED with what? Burn involving 20% total body surface area. Which of the following is true regarding the management of this patient? So you have to calculate, meaning calculate his dose first. I don't have a calculator here. So you will calculate percent total surface area times body weight in kg times 2. That's in 24 hours. Then you will give 1/2 in the first 8 hours, and then the other half in the subsequent 16 hours, right? Yeah, so it is A. If you calculate 65, which is his weight, times total body surface area, which is 20, times 2, that's 2,600 milliliters. So in the first 8 hours, we'll give half of it, which is 1,300 milliliters. That's in the first 8 hours. And the next 1,300 milliliters in the subsequent 6 hours. So option A matches with our calculation. Now, let me ask you a question. If you have someone who's presenting burn, they have their entire right arm having deep partial thickness burn in the entire right arm. In the entire left arm, there is a superficial, that is burn, superficial, grade 1 superficial burn. Their anterior chest has 3rd-degree burn. What is the total body surface area affected in this patient? Yeah, what do you think? Let me repeat. Entire right arm has deep partial thickness burn. All of the right arm, deep partial thickness burn. The anterior chest have 3rd degree, that is full thickness burn. The other arm have superficial burn only. What is the total body surface area of burn? 27. Okay. So the entire upper limb is how much? Entire upper limb is how much? Entire upper limb is 9. The front of the chest is, the front of the chest only, front of chests. How much is that front of chest? 9. So 9 and 9, 18. What about the other arm? Superficial burn, not calculated. So what I'm trying to tell you is that in calculation of total body surface area of burn, you take partial thickness or full thickness burn. Superficial burns are not counted as a part of the total body. So fluids are not given for superficial burns. That's very important, very, very important. Because if you calculate the superficial area, you will give over resuscitation. Okay? Superficial burn not counted. That's the take-home message. That's it. Perfect. Let's see. Very easy question. Simply, 11-year-old child brought by the mother, pruritus ani, anal scotch, shows eggs. What's that? That's Enterobius vermicularis, right? This parasite have a love story. There is a nice love story with this parasite. Do you know the story, the love story of this parasite? It's all about sacrifice. The husband sacrifices for their wife, and the wife sacrifices for their kids. It's all about sacrifice. When the egg is ingested, it will hatch into male and female parasite. The male and female parasite, they couple, right? And once the coupling ends, the male dies. The pregnant female continue on her own to the anus. She will emerge usually at night and lay eggs and then die. Very romantic. Yeah? All partial thickness burns are calculated, Dr. Muhammad. That is, superficial or deep partial thickness burns are calculated. Superficial and deep partial thickness, any partial thickness or full thickness is calculated. But first degree superficial burns, those are not calculated. Okay. What's the treatment, if you can remind me with that? Treatment for Introbius vermicularis. Treatment. Yes, like albendazole, right? Mebendazole, albendazole, those things. Okay. That's the last question that we will take. It says a 49-year-old man diagnosed with pulmonary TB. Which of the following histopathological feature most typical of a tuberculous granuloma? Tuberculous granuloma. Yes, B. There are mainly macrophages that form epithelioid cells with a center of caseating necrosis. Now I have a few questions for you. What is the lesion that you see in primary TB? What's the name of the lesion that you see in primary TB? Means someone just got the infection. They are not previously sensitized. They are not previously. It's called Ghon's focus. Excellent. Ghon's focus is, let me tell you, that's a lung. Okay. Ghon's focus is an area of inflammation in the lung, right? Yes. That forms usually subpleurally under the pleura, peripherally, in either the lower part of the upper lobe or the upper part of the lower lobe. The location of Ghon's focus is lower part of upper lobe or upper part of lower lobe and subpleural. In addition to, what is that? Tuberculous lymphangitis and tuberculous lymphadenitis. Tuberculous lymphangitis and tuberculous lymphadenitis. This is, all of that is called Ghon's complex. Now, if it heals, it forms a fibrocalcific scar, right? This will end up, if the patient, most patients actually, this will be subclinical and will not cause any symptom, or it may cause mild flu-like symptoms. But in most of the cases, this will end up as a fibrocalcific lesion. What's that called? What's the name of that? I'm about to be impressed by someone. So if Ghon's complex heals, what we call it? What's that name? If it heals, it's called? Yeah. If it heals, it's called Ranke's complex, right? Everyone knows Ghon's complex, but I want you to be extra special. You have to also know that when it heals, it's also called Ranke's complex, okay? Now, this is called primary TB. Secondary TB usually occur in the apices of the lung. It appears as an irregular cavitary lesion in the apices of the lung. That's secondary TB in a previously sensitized individual. Okay, so what culture media that you know in the diagnosis of TB? How to diagnose TB? Ziehl-Neelsen stain is a stain. It's not a culture media. It's not culture. Leuenstein-Jensen media. Yes, that's one type of media called Leuenstein-Jensen media. That's a solid media. Another solid media is called Middlebrook. So you have solid media, Middlebrook, and Leuenstein-Jensen media. And then there is also liquid media. Solid media, in solid media, results usually appear about 6 to 8 weeks later. So in solid media, it takes very long time. Liquid media are now better. Liquid media takes about 2 weeks or so to get the result. Liquid media like, yes, Mycobacterium tuberculosis growth indicator tube. Mycobacterium tuberculosis growth indicator tube, or also the automated version of that's called Bactic media. Bactic, okay? Bactic, MGIT. This is a more better way of killing the organism. Bactic, okay? And there's also stains, sputum culture or other stain. There are two kinds of stains. All the stains, the Nielsen stains any acid-fast bacillus. The better than stain is called rhodamine auramine stain. It's a fluorescent stain. That's called rhodamine. It's more preferred nowadays. Rhodamine auramine stain. It uses a fluorescent microscope. Rhodamine auramine staining is better. Okay. Now, is there any fast diagnostic method of diagnosing TB? Quick way and relatively accurate way. Other than cultures, other than stains, other than those traditional methods, is there any other method that you know of that can get you rapid diagnosis in a reasonably accurate fashion? That's called also, yes, interferon gamma release assay, right? I'm sure you've heard about that before. Is it clear now, hopefully? Great, okay. So it must have been over, I don't know, Google Meets or something. So my question was, let's come back to this diagram. My question was, we've talked about Langerhans giant cell, that it has horseshoe shape arrangement of the nuclei to one pole of the cell. That's one. And then we've talked about it is foreign body giant cell, that it has just scattered nuclei throughout. And then I've described a cell, and I want you to guess what it is, right? I said that there's a type of giant cell that has its nuclei arranged as a ring, and the cytoplasm is clear and foamy, right? That was my question before the voice started getting bad. Foamy, macrophage, foamy cytoplasm, ring-shaped arrangement of nuclei. What's that? It's called Taunton cell. That's called Taunton giant cell. Okay. That's called Taunton giant cell. My next question is, Taunton giant cell is seen in which condition? Yeah. That can be a question in the exam. Taunton giant cell. It's seen in which condition? It's a relatively common condition. Excellent. Dr. Muhammad said xanthomas. Yes, it's seen in xanthomas, right? It's seen in areas of fatty damage, like fat necrosis. It's seen in xanthilas. Basically, these are giant cells laden with lipid, right? That's correct. These are called Taunton giant cell. So know these three types, just these three types for the purpose of the exam. Langerhans giant cell and foreign body giant cell and Taunton cell. That's what I want you to know about. Okay. Perfect. Great. We're doing great. Okay, let's see one more question, and then we'll wrap this up. Okay. So this question is saying a 30-year-old man undergoes an abdominal operation. Is that right? What type of cell will predominate in the wound after 4 days? After 4 days, what do you see in the wound? Type of cell that predominate. Dr. Asma said neutrophil. Neutrophil is just in the first or second day. It is a very early change. 4 days, 4 days is a lot of days. 4 whole 4 days, right? The wound is in which stage right now? So yes, so you said it is C. That's correct, the fibroblasts. Let me explain. Look at here. Stages of wound healing. First, hemostasis, okay? We're not gonna focus on hemostasis right now. Then what will be after that? Inflammation. The stage of inflammation is divided into 2 subphases. There is the early inflammatory phase, which is the first and second day. During the first and second day, the main cell is neutrophils, polymorphonuclear leukocytes, right? Neutrophils will be the main, please remember this, write this down. Which day, which cell will predominate? Write this down in your notes. First and second day, early phase, it's neutrophils mainly, okay? Then late inflammatory stage, second and third day, the main cell will be macrophages in the wound, okay? So first to second day, neutrophils, second to third day, mainly macrophages. After the third day, we will be in which stage? Proliferative stage, right? Proliferative stage of wound healing. It's after the third day, okay? And it will last for 2 to 4 weeks. The main thing is the formation of granulation tissue. What's granulation tissue? Proliferating blood vessels and fibroblasts. That's granulation tissue. So it will mainly consist of fibroblast activity. By the way, this article is copy-paste from Bain. This article is copy-paste from Bain. Right? So these numbers are more accurate than you see in the MRCS or in any other place, because that's copy-paste from Bain textbook, which is the main resource used by the Royal College itself in the exam, in their exam curriculum. So again, let me repeat, because I'm stressing that's very important for us. Inflammatory phase, early, 1 or 2 day, neutrophil, 2 or 3 days, macrophages. Proliferative phase, which is after the third day, meaning 4th and beyond, until 2 to 4 weeks. That's mainly fibroblast activity. Fibroblast activity, okay? So again, I'm not gonna go into detail. The main resource is Bailey and Love's textbook of surgery. You should use the last edition if you want to study from that, 28th edition. Of course, it's a huge book, so it will need a lot of time and a lot of preparation to finish that book. So it can be not that practical to study for an exam purpose. But if you want to refer to it to confirm something, I think that is the best. No, there's no anatomy. It's just a surgery textbook. It's just a surgery textbook. Anatomy, I recommend Gray's Anatomy. Gray's Anatomy, I recommend that, or Teach Me Anatomy, which is a more simpler form. But if you want to go into more details of anatomy, Gray's would be good. But again, those resources are very thick and huge. It can be unpractical to study it for exam. Use them as reference point if you want to go back and confirm something, only as reference point, okay? So after that, there's remodeling. I'm not going to go into detail of how the wound will heal and things like that, because there's a whole lecture on the website, right? it's gonna take time because it will take an hour or so to explain the whole stages. Okay, so that's the end of our session, guys. So what do you think? Do you think that you've got some benefit out of this session today? Okay, thank you very much. Yes, someone raised the hand. If you have any questions, just ask me. Do you have questions? No more questions. Okay, great. So I will meet you according to our schedule that I've posted on the public channel. I'll meet you again, inshallah. And the next session will be very challenging. All of the questions in the next session will be very challenging with a lot of concepts to cover. Study well, and I will see you next time, inshallah. Thank you so much for your time and for your attention. Thank you.